I was asked to cover a fairly broad topic on antibody-based therapies and bispecifics and their evolution and development and future directions in acute myeloid leukemia. I spoke about antibody-drug conjugates that have been developed in AML, the old, the recent, and some of the other ADCs being studied now. So we covered Gemtuzumab, Ozogamicin, we covered Flotetuzumab, Talarine. We also covered some of the newer antibody-drug conjugates, including the one from ImmunoGen, which is mainly targeting CD123. I think these are promising agents. They can be quite potent. The challenge with antibody-drug conjugates are historically twofold. One is the relationship potentially to liver toxicity, especially not across all ADCs, but specifically related to Gemtuzumab, Ozogamicin. That toxic effect seems to have been ameliorated as a result of reducing the dose and fractionating the dose to the extent that we now use it fairly frequently in a subset of patients, and it is approved for use in the United States. Some of the other drugs that have been studied have been impacted by bystander effects from likely release of the cytotoxic payload of these antibody-drug conjugates and causing local injury to normal hematopoietic cells. So marrow suppression is oftentimes a common challenge with antibody-drug conjugates. However, some of the ADCs continue to be developed. For example, the drug that I mentioned targeting CD123 from ImmunoGen, that drug showed fairly impressive reductions in blasts and a number of marrow responses, including complete remissions. We'll have to see where that drug ends up, both in relation to AML as well as to BPDCN, which is a rarer form of myeloid neoplasm. I also spoke about bispecifics. There's many different types of bispecific, but probably the two most known groups are BiTEs, which are the traditional bispecific T-cell engagers, as well as DARTs, which are the dual-affinity retargeting molecules. Both of these have antibody components, IgG components to them that target both the CD3 on the surface of our T cells, as well as a target antigen on the surface of the malignant cell. In the case of ALL, that would be the traditional ALL antigens of AML rather, the traditional AML antigens of CD33 or CD123 or perhaps others that are under development. And these drugs are also under study and have shown a good amount of promise. As an example, just one, Flotetuzumab recently was published in the journal Blood. It was presented in recent years and seems to have some good efficacy in patients who have primary refractory disease or have early relapse of AML. It's a very challenging population of patients who have traditionally done very poorly. So maybe it has legs in that group. There are also some traditional side effect profile challenges with bispecific agents, namely the development of cytokine release syndrome, which does impact almost every patient that's treated, but mostly mild or moderate. Grade 3 or higher CRS is much less common in the newer generation of BiTEs and DARTs under study.